thank you everyone for coming today, and appreciate the attention. This is the third time we've done this today. We've had good attendance at the earlier two meetings, and good news is that we've worked out some of the kinks, so you don't have to tolerate some of the things that went on first thing this morning. But I appreciate you coming. We've got some good information that we want to share with you, and hopefully end it up in time to answer some of your questions. But the title of what we're doing this afternoon is realigning DMA, realigning to best serve the people of North Carolina today and beyond. And I want to give you an idea of a lot of work that has gone on in the last several months looking at our division in terms of realigning, and I use that word, not reorganization, but realigning positions and what we do to match certain functions that we think will be important as we move into the future. Just want to give you somewhat of a background. I know a lot of you have an interest in two areas, and I want to update you where we are with that. One is, there's a debate going on right now. Where does DMA live? Does it live within DHHS, or does it live outside of DHHS as its own department? And there's also a debate going on in terms of what payment method that we're going to use for the future. Is it going to be an accountable care model, ACO model, or is it going to be an MCO model? First of all, with the latter question, the ACO, as many of you know, about a year ago, March 2013, the Secretary and Director Steckel at that time presented a model that was based on the MCO model, Managed Care Organization model. And a lot of time and effort had gone into that particular model, but as the Secretary and Director Steckel went out and talked across North Carolina to the providers, it was pretty clear that the providers had other ideas about what would be the best way to handle our Medicaid and our method of payment going forward. And really basically said that they didn't support the MCO model for a number of reasons that many of you probably know and have read about. And so the Secretary came back and discussed that with the Governor, and there was and the decision was made to hire a couple of consultants who came in, and those consultants' job was to go across North Carolina, talk to the providers again, and say, well, what would you support? How do you think we should move ahead with payment reform for North Carolina? And out of that discussion came the idea of accountable care organization. So if you look at the spectrum, you've got fee-for-service on one end. That means that I do something and you pay me for doing something. And on the other end, you've got managed care, which is I've got a population of people, and I'm going to give you a check, and you pay for you take care of those people. And if you spend more than that check, that's your problem. If you spend less than that check, then you made a profit. So managed care, fee-for-service. And somewhere in between is something called accountable care, an ACO model. And we like the ACO model because it emphasizes keeping the patient and the doctor, the provider, at the center of the equation. Let the provider, let the people who direct the care, take care of the patients, be the ones calling the shots in terms of how care is delivered, and be responsible for saving money and being accountable to maintaining a budget. So the ACO model was the model that we proposed back on March 17th. We sent a very detailed plan to the General Assembly on the ACO model. And many of you know that was debated back and forth. Eventually, the Governor's office strongly supported that model. The House of Representatives supported that model. 100% hasn't happened often, as you might imagine, but 100% of the House voted for that model. Bipartisan support. The Senate did have a different view of how to move ahead with payment reform, and they favored the managed care organization model, the MCO model. And I tell folks that we're all trying to get to a certain end. Everyone's trying to figure out what's the best way for Medicaid. What's the best thing that we can do for Medicaid to make it sustainable and predictable for the future? There's a little bit of discussion going on about how we get to that point. And so the Senate has the idea that the MCO model is a bit more predictable. And that's what they're looking for. We want a number that we can put into our budget that we can then be sure that that number is going to be a real number, and then we can make other decisions regarding things like education and public safety and other aspects of North Carolina government that they have to pay attention to. And so the Senate feels like the MCO gives them that level of predictability that they want and that they need. So that debate is going on right now. The other debate that's going on right now, again, is does DMA live within DHHS, or do they pull it out? And no decision has been made on either front. It's a healthy debate that's going on. People are talking back and forth. There are 4 committees right now that have been formed to look at various aspects of those two questions. We have the Secretary will be presenting tomorrow to a subcommittee of the Program Evaluation Division. PED has a Joint Legislative Oversight Subcommittee, and that committee is meeting tomorrow. The Secretary will be presenting at that committee, and we'll be talking to them, answering the question of, well, tell us what you're doing, Secretary, with DHHS, and specifically with DMA. Our philosophy, our belief is that we're doing some good things. We're doing some really good things with Medicaid. We think that the one good sign that we're doing some good things with Medicaid is the fact that we ended up our budget for the first time in 4 years in a positive way. Now you can say, well, that money may be owed. We don't know that for sure, but the bottom line is, you know, last year we were looking for $500 million to fill a hole. This year we reverted $63 million back to the general fund. So that's a fact that you really can't argue with. And so we feel that that's just one sign that we're moving in a positive direction with DMA. And our argument would be, let us continue down the path that we've started. We started a path 20 months ago. We're beginning to see some fruit. Let us continue along that path. So that committee tomorrow, the PED Joint Legislative Oversight Committee, will be looking at that question of, does DMA stay within or do we pull it out? There's another Joint Legislative Oversight Committee that was set up by the LOC that we presented at last Tuesday. Some of you may have seen that presentation, what we did during that day. They, at the end of the day, were very, very complimentary of what we do. We had several strong, if you did watch it, you saw at the end, just a couple of senators, a couple of representatives really, really were very complimentary of the good work that's gone on within DMA and so forth. One senator even suggested that we should double the Secretary's salary, which would be, and I offered to pay that. I could afford it. So that committee will be looking at what is our payment plan going forward, and also where should DMA live, within or without of HHS. The governor has a commission that he's setting up to look at this issue. And then finally, within HHS, we've set up a cross-divisional committee that will be looking at Medicaid reform and how do we proceed in the future. I've had several provider groups approach me and ask the question, how can we help? They like the ACO model, which we continue to support. We're not wavering on that. HHS continues to support the ACO model, and the provider groups that we've discussed it with also support that model. And so they're asking us, how do we continue to move along this path that we've started? What can we do to assist you? And so this group will be working to how can we use our providers? How can we work within HHS? What do we need to be doing between now and January when the long session resumes that would help move the ACO model forward, number one, and number two, keep DMA where it is within HHS. Those are our two stances there. So a lot of debate. Medicaid is big business in America today. There are 55 Medicaid programs across the nation. And North Carolina is not unique with all this discussion. Don't be fooled. We're not undergoing something that everybody else has got it together. We're over here trying to figure out what to do. Every one of those 55 programs are having this debate. What do we do with decreased resources, increased demand? How do we handle technology? You know, how do we move ahead? How do we make Medicaid sustainable? So we're in the same debate that a lot of folks in. Medicaid in most states really is the primary driver of the budget. And in North Carolina, it is one of the primary drivers of our budget. And so that's why it's getting a lot of attention. There are Medicaid programs that range from 100,000 beneficiaries up to Medicaid programs with over 10 million beneficiaries. And there are Medicaid programs that go from $500 million in budget up to $55 billion, with a B, billion dollars in budget. So you're talking about a lot of money that folks are trying to deal with, and how do we get ready? How do we make that sustainable and predictable for the future? So North Carolina is just like every other Medicaid program. We're having a very lively debate about how do we move into the future. So I want to cover 3 areas here today as I talk to you. I want to give you the results of a retreat that the leadership of DMA had. We pulled the leadership together on 3 different occasions, took them off to an off-site, and there's a lot of debate back and forth talking about our mission, our vision, and our values moving forward over the coming year or so. I want to give you some information about the realignment, how we've looked at what it is that DMA does and how we can better prepare to meet the needs of the future. And we want to give you a quick summary, just a few words about the communication survey that we just sent out, which, by the way, we had over 60% response, which is phenomenal. Julia tells me that usually in a survey like that, you'd have about 20% response. So we had great response from that particular survey. But as we poured together the leadership and we said, let's talk about our mission. What is it that we see ourselves doing? Let's talk about our vision. Where do we see ourselves going down the road? Where do we want to be? And then we also want to talk about some values. We decided there were some guiding principles that we needed to use. First of all, we want to build on what we do well. You don't administer $13.5 billion, take care of 1.8 million people in the state of North Carolina if you're not doing something right, if you're not doing something well. We're doing a lot of things good, so don't let anyone fool you that DMA is doing a lot of good things, doing them very, very well. And so we want to build on that. We don't want to take away from it. We also talked about the fact that there's so much change going on right now, and I've just told you about 2 debates that's going on right now downtown on John Street and on our campus, and so it's hard to predict what's going to be happening 3 years, 5 years from now. In fact, I'd say most folks would say if you're going much beyond 3 years, it's sort of a flip of the coin, certainly at 5 years. So we decided that what we were going to do as we looked at our mission, vision, and values, we're going to focus on the next 12 months. The next 12 to 18 months, where do we want us to go? What do we want our mission and our vision to be? And but on the other hand, we do want as much as possible to establish a foundation for the future. We know that we're either going to be within HHS or we're going to be outside. We're going to have an ACO, or we're going to have an MCO. So let's not ignore that that's going on. Let's say whatever we do now, let's keep that in mind and make sure that what we're doing now will work for that. In fact, as we presented some of this information last week to some of our key legislators, that was one question that a couple of them asked. You know that this debate's going on, Robin, DMA. Given what you're presenting to us, will this fit any of those models? And our answer was yes. It may require a bit of tweaking around the edges, but we believe what we're presenting here can work, whatever the answer to those 2 questions might be. So our mission, a lot of give and take. We had mission statements that were several statements long, and Sabrina was 2 paragraphs long, couldn't stop her. No, just kidding. So we had a lot of healthy debate back and forth of what our mission should be. And we finally ended up that we wanted it to be something that was short, that folks could hopefully remember. It'd be nice if folks walk up to you in the elevator or wherever you are and say, what is the mission of DMA? Our goal would be that you could repeat that to them. And so one statement that we really liked was something that Jeff Jeff Horton said that Dr. Gray, who was the Medicaid Director some time back, used to say something about using the power of Medicaid to improve the health of North Carolina. I really like that statement. We really like that statement. We didn't use the power part of it, but we did break that power part into using the resources and partnerships of Medicaid to improve health care for all North Carolinians. So Medicaid, $13.5 billion, covering 1.8 million lives. Last year it ticked up to about 2 million. There are only less than 10 million people in North Carolina, so at some point last year, Medicaid was touching the lives of 1 out of 5 people in North Carolina. With all of that, you're talking about a lot of resources. If we look at our providers, if we look at the hospitals, if we look at all the folks that are working with us, that we work with, those are tremendous partnerships. So using the power in terms of resources and partnerships of Medicaid, and we also see ourselves as affecting all North Carolinians, not just our Medicaid population. Obviously that's our first love. Those are the people that we're responsible for. But if we influence Medicaid and the way Medicaid is delivered, we will influence the way health care in North Carolina is delivered. If I'm a doctor in my office and I have a patient who comes in, I don't look at the chart and say, oh, this patient's Medicaid, so I'm going to treat their high blood pressure this way, or I'm going to do this test on them because they're Medicaid. That does not happen. So if we change the way that doctor looks at that Medicaid patient, takes care of that Medicaid patient, the next patient who walks in who's Medicare or uninsured or insured with insurance, you're going to treat that patient the same as you did your Medicaid patient. So by doing some of the things that we're talking about with the ACO and driving quality metrics that maybe some of you have heard, by doing that, we're going to be able to drive health care for all North Carolinians. We are leading when it comes to that. And so that comes to our vision, leading. There is a tremendous transformation going on. I've given you a couple of examples, and again, this is a nationwide thing. This is not something just in North Carolina. There's a transformation going on in healthcare across the nation, and certainly here in North Carolina. Again, we see Medicaid as leading that transformation with a goal being to a healthier North Carolina. Now, I hope you like those. If you do, that's great. If you don't, they'll change in 12 months, so hang in there. But we're going to be working with our communications people to put these across in all of our locations, to put them in areas, so that it's important that as you do your job, you have a mission in mind, you have a vision of where we're all heading. We need to develop that culture here in DMA, and a lot of what we're doing, by the way, is to try to develop that culture. So here is our mission, using the resources and partnerships of Medicaid to improve health care for all North Carolinians and leading the transformation to a healthier North Carolina. Values. All of us have values, lots of values out there that we can talk about, but we wanted to pick 5 that we thought would lead us for the next 12 to 18 months. And we talked about what's important for us and what's important for you, and what would we want you to emphasize in your daily activities in Medicaid. Accountability, own your work. It's not acceptable to say, well, that's not my job, or I just did my part of it and I'm not responsible. I don't care about this part that fits into the bigger puzzle. You need to see how your work does fit into that big puzzle, what value it brings to that big puzzle, and take pride in that work. We want you to own that work. We want you to, if you see something that's going on in your area and you're not happy with it, please let somebody know. You really should, because of all the people who can help improve Medicaid, I would think it's the people who work in Medicaid every day. You folks work here because you're committed. You're committed to your patients, to our beneficiaries. So let's work to improve DMA as we move forward. Integrity. Own your actions. What you do reflects on yourself, obviously, reflects on DMA. So integrity. Whatever you do, do it with integrity, with a sense of integrity. Collaboration. Value partnerships. One of my pet peeves, if someone calls one of our folks and says, I got a problem, and I'll get these calls sometime, well, I called your folks and I got moved from person to person to person. This is a person who's calling you because they need help. And you should look at them as one of our partners. And my job is to help you. And if I don't know your answer, then let me help you get an answer. My goal should not be, let me get you off the phone, get you to someone else as quickly as possible. Let me help you find the answer to your question so that you can go about and do your job. And we have many, many partners that we work with. Innovation. It's so easy to come up and say, I have a problem. This is not working. That's bad. NC Tracks is horrible. NC Fast is horrible. All these things are going on. There are we still have a lot of problems. Obviously, that's not a revelation to anybody. We still have a lot of issues, a lot of problems going on. So when you come forth and you bring a problem, don't be shy about identifying a solution. Again, you're doing it. You, better than anybody, would know in that area right there, and maybe even in a bigger area, what could be a good solution. And don't be shy. Sandy and I and Dr. Henley and all the leadership in our executive committee, we're encouraging our leadership to listen to your people, to have regular meetings, agenda-driven meetings, but also have time to talk. Listen to your people and let them tell you what are their issues, but also bring solutions. Take an extra time to not only identify the problem, but if you were in charge, how would you solve the problem? And then finally, communication. If there was one thing I heard when I came and took over this position, was communication. So many of you said, I usually find out what's going on in Medicaid in the newspaper. I can tell you that we're making a concerted effort to change that. You're hearing about this reorganization plan. We did talk to some of our key legislators last week, but we're having 4 of these sessions today, and we're going to be talking to about 200 of our folks, and we're talking to more using a web connection and so forth. And then this afternoon, this information will be released to the press. So you're hearing about it before we've released it to the press. If it's in the press, it's not because of us. You're also hearing about it. We notified our division directors about it this morning after we started our first session and so forth. And many times, if we have something to release to the press, we've developed the habit of notifying you guys out in an email maybe 15 or 30 minutes before. Now there's reasons why sometimes you have to time things and so forth, but our goal is to let you know what's going on in DMA before someone else knows. You should know before that, and we try to get all the input so that when we make those decisions, they're solid and good decisions. But communication within DMA as well as communication from the outside is very, very important. Had one of the legislators told me last week, we went and we talked to him about this particular proposal, about what you're hearing about today. He liked it, and he said, I really appreciated this time that we spent together. And he says it's important that we talk, because when we're talking with you guys and we're sharing, that's good, because if we're not talking, then we as legislators begin to assume and begin to wonder, and when we do that, then usually it ends up with us doing a lot more work and really not having the kind of progress that we want and need. So communication is something that we're emphasizing at all levels. And we got a lot of information on the survey that we'll be incorporating. So that's our mission, vision, and values. I want to talk about now what we've done with our realignment. And so Medicaid was formed in North Carolina in 1970, 1971. And although there's sort of been, I've talked to five of the last Medicaid directors, there's been some effort here and there to make some changes in Medicaid, but there's never been a concentrated effort to look at the whole picture, try and look at what's going to happen in the future, and reorganize, realign Medicaid according to those principles. So this is the first time. One of the challenges that we had for A&M, who are our consultants, contractors who have been in here and who've helped us do a lot of this work over the last few months, one of the issues that I think we face, we're a $13.5–14 billion industry, corporation, company, whatever word you want to use. this person, which I have, hold that office right now, this person changes pretty frequently. I had an AD when I came on tell me that you're the 5th Medicaid director that I've had in 3.5 years. Now just think about that. What $13 billion company can tolerate having the leader of that company come and go at that rate? In North Carolina, again, is not unusual. The median tenure for a Medicaid director across the United States last year, 18 months. 18 months. Now, it did increase to 20 months just, I think, 6 months ago when they did the study again, but certainly far less than 2 years is the median tenure for a director. As we realign and reorganize our organization here in Medicaid, one of the challenges we had was how can we minimize the impact of that person leaving, because that's just the nature of the beast. It's going to happen. They're going to come and go. The longest serving Medicaid director in the United States is 8 years. There's actually 2, and one of those quit last month. So there's one person who's been in the business, according to what I've been reading, for 8 years. And if you looked at the organizational chart that we had, you had the director up here, and then you had leader of finance and leader of operations. And many of you know that, you know, below this you'd have many other boxes of folks who filled in below that. And within the last 12 months, all 3 of those positions have changed in your organization. So again, we wanted to realign and reorganize in such a way that when that top leadership changes, you guys continue. This AD who was talking to me said, well, with one Medicaid director we go this way, and then another one comes and we go that way, and another one comes. You know, we need to have it that Medicaid is moving forward. You can change leadership, but somehow that leadership has to fit within the Medicaid program and what's going on in Medicaid as you move forward. So this is what we had in place today, and this is what we're looking forward to for the future. Still have the director. We have here the office of the director, and there'll be eventually 3 people in this particular box. And keep in mind, by the way, all this will be on our website later on today if you want to go back and look at it. 3 people will be in this box, and the purpose of this box is that, you know, every day when your leadership, when we come in, most days we have a standing joke now, what's the crisis du jour? What's the crisis for the day? So you walk in and you say, well, what fire is burning today? And sometimes it's not just what fire is burning today, it's what fire is burning the hottest today that I have to focus on. And you can't really lead and direct an organization if all day long you're handling problems and challenges. You have to have an organization where somebody is looking toward the future. So this office, their goal will be to look toward the future, to keep their finger on the pulse of CMS, to know what the legislators are thinking, to sort of have the big picture in mind as we say, where do we want to be a year, 3 years down the road, maybe even 5 years down the road if you're feeling bold to project that far out. But that's what that office will be, is folks sitting within that office to help the director shape Medicaid as we move ahead. And then what we did is divided down here 5 functional areas. We got the function of finance, function of operations, compliance and oversight, clinical, and business information. And so all of these are very, very, very important. And again, if you look at these as we move ahead into the idea of DMA being inside or outside, MCO, ACO, any one of those are going to need finance, right? No brainer. I can tell you any one of those is going to need compliance. In fact, more compliance, if anything, compliance and oversight. We just met at 12 noon, and this morning we had a regulator from our regional office from CMS and Kirby asking questions, and appropriate questions. I mean, people should expect to have oversight. There's nothing wrong with that. We should be prepared to answer that oversight. So that person's come here. Right now we're having audits. I think within DHHS we've got 40, 50 audits going on. Within DMA alone we've got somewhere around 20 audits going on. So that compliance and oversight is just going to increase, if anything else. Business information. DMA gets so much data. We deal with so much information. And that information, knowledge is power. We can take that information and it can help us take care of our beneficiaries more efficiently, and it can help us to maximize our resources so that we're not only taking care of our beneficiaries and hopefully taking care of more beneficiaries, but we're also watching our resources very closely. And you do that by information. Tell me what's going on in this program. Break down that program. Tell me what's going on within that program. Tell me what's going on with the patients that program is supposed to be affecting. Tell me about the providers. We should be able to put numbers with all of that stuff. That's the future. And then obviously operations and clinical will be important as we move ahead. At this point, I'm going to ask Nick to stand up and just talk a little bit about finance. But within the section of finance, we've broken it down into 7 units here. We have 1 unit up here, budget. We've been able to find someone that we feel is very, very talented to lead that particular section. We've already started putting out posting for others to lead some of these other sections as well. But Nick, just comment on this if you would.
So along with the theme of, in the reorg, which is, or the realignment, is the grouping of logical functions. How do we put like-minded people together? And so what we try to do on the finance side is, finance is support. It's the reason, it feeds the mechanism, which is DMA. So how do we align the finance group to support the programs? And so what we would like to do is say, what used to be the budget group has been broken into 3 or 4. So you have the budget now, finance and accounting, and you have forecast planning and analysis. So break down those 3 disciplines and start having people own those programs, be responsible for them, understand the trends, and most importantly, work closely with the program people so that they understand that as you make program changes, what are the implications from a financial perspective? What is the change on my budget? What is the analysis on what this policy will do or what this policy won't do? And so, once again, putting like-minded people together in the finance group and then breaking it down into disciplines.
And so if you look down here with the actuarials, we have 1 actuary in our division. Blue Cross Blue Shield has 25 or so in their company. The General Assembly has been pretty generous, was generous with us in the sense that they knew that we needed this assistance, and for various reasons there were challenges with it, but basically they put money in the budget to allow us to hire 2 actuaries for next year, and those have been posted, and we're getting those people in place. That will give us 3. We talked to them last week. Is that enough? No, we don't think that's enough, and they're going to work with us. Again, we're getting a lot of support from a lot of folks to move Medicaid in a positive direction and to help us reorganize. If you look in the area of operations, you can see how we've divided. And again, now these are functional areas, and there may be many, many people represented by any one of those boxes. These are not specific people in most cases. But with operations, Sandy, would you like to comment on operations?
Sure, thank you, Dr. I want to call your attention to the quality and risk. That's a new function that we've identified as a need for DMA enterprise-wide. Risk, obviously, looking at proactively and identifying risk before it happens, and then it turns into an audit and then a compliance issue, and we know that path very well. But also looking at quality and quality outcomes as we stand and look for the future of either an ACO-MCO model, obviously, and with our current meaningful use requirements now reporting to the federal government. Quality will take a different perspective for the agency, and so this is a new entity or new function within operations that will not only measure and identify how do we prove and demonstrate we're improving the health care of all North Carolinians and the health status, but also identifying risk proactively and then mitigating that risk before it does turn into an issue for the agency or for the department.
So if you look at within compliance and oversight, and we were just over at Six Forks this morning presenting to them, and obviously they were interested in program integrity. A good number of them were. Program integrity is something that's going to be emphasized for the future, and there are a number of reasons why that's the case. But just the oversight of all of our contracts, DHHS has almost 1,600 contracts. DMA has about 64, 68 of those contracts, but by far we carry the boatload of the money associated with contracts in DHHS. And the oversight associated with each of those contracts is not going away, and it's not decreasing. If anything, it's increasing. And really, we should expect that. If someone gives you $2 billion to lead an organization, you should expect that they're going to come in and say, well, show us how that money is being used, show us the return on investment, show us that our patients are being taken care of. Prove it. Don't just say we gave the money out and folks are using it and so forth. So we want to have an area, an individual who will be overseeing this group that will be heading up oversight of contracts. HIPAA, don't have to say a whole lot about the importance of HIPAA for the future. Within the clinical area, these are the various aspects making up the units making up the clinical section. And then business information. This section is probably the one that we've developed the most to date. We've done a lot of really positive things have already gone on within the business information section, and we continue to do some additional, beef up some additional areas as well as we move forward. So those are sort of, that's the organizational chart. Now I know that's probably not the kind of detail and as much detail as maybe you were hoping for. This is the big picture. What we're doing today is we're rolling it out. We've had many months of discussion among ourselves, discussion with folks downtown, discussion with many OSBM and so forth. And we're now to the point where, okay, everyone's happy. We can now, let's roll this out and start telling the world about it. And that's where we are right here. After we finish today, we need to start putting some budget numbers to it. Then we'll start having some working sessions where your leadership, the folks in charge of your section, present section, will come together and they're going to start talking. Well, this is where I think this should go. This is how I think this fits into the future. So those discussions will start pretty quickly. And our goal is that by December, we will finish with Group 1. We're going to do this in 2 phases, roughly. Group 1 is going to consist of finance, compliance and oversight, and business information. Those 3, and a little bit of the Office of Director. So those 3 and a little bit of 4 will be done between now and the end of December. So we're now on a pretty quick timeline in terms of things happening. So a lot of discussion going on. That'll be Group 1. Group 2 will look at operations and clinical. And that will take place, the fine touches on that will take place end of November, December, into the first quarter of next year. And one reason that we put off operations and clinical is because we want to try to get a better feel for where we're going with ACO versus MCO, because that might influence some of our decisions of how we move forward with operations and clinical. So that is that's the reorg as in terms of where we stand today. You're going to start hearing a lot, and your leadership will now get even more involved. Your leadership really has been involved in this process. I don't want to lead you to think that they haven't been involved in this process. Nick, who's been the head consultant on this particular project, has had over 150 interviews. And most of those interviews have been one-on-one interviews. Some he's gone and talked to groups, but well over 150 interviews he's conducted to get the information to get us to this point, and now to help guide us as we try to sort through some of the details as we move forward. With our communication survey, just quickly, you clearly want more information, and you need that information in order to do your job well. That was one theme that we heard quite a bit. We don't want the media to be the source of your information, and you don't want that. You would prefer to receive it internally, and I can tell you there is a concentrated, sincere effort to make that happen. If you hear about something that's happening in DMA and you didn't hear about it first, there will be a very good reason why it will have to happen that way. But as much as we can, our attempt is to make sure that you hear about it first. You receive valuable information from leaders, but you don't hear from them often enough. We're encouraging your leadership to meet with you on regular meetings. Those meetings should have an agenda associated with them, but those meetings should also have some time for you to talk and have some back and forth with your leadership and amongst yourselves, so that you can sort of visualize what's going on. And I know you guys are working. I know your plate's overflowing, your saucer's overflowing, and you don't have a whole lot of time and energy some days. But we've got to somehow get to the point where we step back and start taking a deep breath and looking to the future of DMA. And then opportunities, there was a lot of discussion about opportunities to improve meeting efficiency rather than having fewer meetings. So you do find the meetings useful, and we just need to be efficient about using them. So if you look real carefully here, you can see there's a little bit of a light right there. And that's either the light at the end of the tunnel or it's Amtrak coming our way. We think it's the light at the end of the tunnel, and we're doing our best to convince people that we think the ACO model is the way to go. We think that DMA should stay where it is. Give us an opportunity. We're doing some good things. Let us complete the path that we've started on, and we believe that it will we'll end up in a good place. Again, a lot of challenges going on. We need to focus on the future. You guys are doing good work. You're doing some great stuff. You should be proud of yourself. You're dedicated. Clearly, you could be doing other things and focused in other areas of life and so forth, but you're here to help others. And you don't get much higher in life than having that as a goal. But focus on tomorrow, because that's where we need to be looking forward to. So